All right, good morning. Welcome to the grand round. And this is going to be taken by the Department of Critical Care Medicine. And they are helped in this grand round by the Department of Microbiology. And they have chosen a very practical and important topic, which is the clinical profile of patients with colistin-resistant bacterial isolates. And I think this is a problem which not only plagues the Department of Critical Care Medicine, but all departments in the institute which take care of sick patients. And so I'm requesting Dr. Afzal Azim to start.
Thank you, sir. A very good morning to all of you. Today, the Department of Critical Care Medicine will present an experience on the clinical profile of patients with colistin-resistant bacterial isolates. This is a collaborative study done with the help of the Department of Microbiology. Now, before we go into the study, I'll just try to give you the background of this study. Now, antimicrobial resistance is a global problem, and it has now been recognized as a major threat to modern medicine. Various fancy names have come, like it is a silent tsunami. The organisms like E. coli, staph, Klebsiella, Acinetobacter, Pseudomonas, which were grouped as escape organisms, for which we were worried about the antibiotic therapy, they have already escaped the antibiotics. UN suggests that the superbugs, that is the bugs which are not responsive to the first line of antibiotic therapy, are the biggest threat to modern medicine. WHO has published several newsletters and suggests the research wings of various societies and organizations that new antibiotics are urgently needed. And they go on to say that it is not just the antibiotics, we also need to develop vaccines for the bacterial infections. And it is predicted that by 2050, 10 million deaths are predicted per year due to antimicrobial resistance. So it's a big issue for hospitalized patients. Now, I'll just talk about a very large systematic analysis published in Lancet in 2019. And why I'm reviewing this is because it is relevant to our settings and relevant to the ICU population. They looked at the global burden of bacterial antimicrobial resistance globally. And I will just talk about the aspects which they have presented which are relevant to us. 3 infections were recognized as contributing maximally to antimicrobial resistance and deaths globally. The first is the lower respiratory tract infection, followed by the bloodstream infection, and then the intra-abdominal infection. And if you look at the purple, the light purple and the dark purple, they represent the associations of these infections with resistance and attribution and how much they attribute to resistance. So 3 infections contribute maximally. Now, what are the commonest gram-negative organisms? I'm not talking about the gram-positive, though gram-positive is becoming a bigger issue for the developed nations. So the 3 commonest gram-negative organisms contributing to death subsequent to antimicrobial resistance include E. coli, Klebsiella pneumoniae, and Acinetobacter baumannii. And this is what they contribute to death. So the highest contributions come from these 3 organisms. Now, this same collaborators which published this analysis, they also tried to look in the different regions of the world. They tried to look in Central Europe, high-income countries, Latin America, North Africa, but we would like to concentrate on the Asian continent, the South Asia, Southeast Asia, East Asia, and Oceania. And when they looked in this part of the globe, they found that the pathogens which are associated with antimicrobial resistance and contributing to death are E. coli, Acinetobacter, and Klebsiella. So again, these are the 3 most common organisms contributing to resistance and death. Now, just to give you a timeline of antibiotics, now what to do with these resistant organisms? If you just have a glimpse of this timeline, you will find that the moment the antibiotics are discovered, this is the discovery of penicillins, and in the next 20 years, less than 20 years, we started to getting resistance against it. Similarly, it was for macrolides, tetracyclines, fluoroquinolones, And within 5 to 10 years, we start getting resistance. And this has been attributed to inappropriate use, inadequate use, lack of timing. So many factors have contributed to resistance, which develops very fast. Now, if you look at the timeline of the antibiotics, in 1985 came the carbapenems. The first carbapenem to be discovered was imipenem. And as soon as it was introduced in the market, it appeared to the clinicians that a boon has come to us to fight the multi-drug resistant organisms. And what happened to the carbapenems? In 1993, we started to get resistance even against the carbapenems. And an important point to highlight in this timeline is that now we are almost 30 years off without a development of a new class of antibiotics. So here I would like to stress the class of antibiotics. Newer antibiotics have come, but we have not been able to get any antibiotic which belongs to a different class which are already existing. So if the carbapenems became our last lifeline for these resistant organisms, now we should also know that what has happened to the carbapenems over the last 2 decades. So it was the drug of choice for multi-drug resistant organisms. And if you look at the global epidemiology of Acinetobacter and the resistance pattern to carbapenems, which has been published in Lancet in 2019, we will see that India is falling in the red zone. India has got more than 80% resistance Acinetobacter to carbapenems. And similarly, what is happening to the next most common gram-negative organism, that is Klebsiella. Again, if you look at the global epidemiology of Klebsiella, which is resistant to the carbapenems, you will find that again India is in the hottest seat. We have got almost 60 to 70% Klebsiella, which is resistant to the carbapenems. And this article also highlights one more point, that this percentage is underreported because of lack of principles of antimicrobial stewardship, which is existing in the developing nations. We do not have the principles or the policies for surveillance cultures, and even the microbiology labs, they are not well established, or they are not so advanced that they can pick up this carbapenem resistance. Now, carbapenem resistance has been identified over the last 2 decades, but what are the factors which are contributing to carbapenem resistance? So people have also tried to look into the enzymes, the carbapenemase, which contribute to carbapenem resistance. And broadly, 5 enzymes have been recognized, like IMP, KPC, NDM, OXA, and VIM. And if you know, and you can see from here, that NDM has been named after New Delhi metallo-beta-lactamase. And if you look at the global epidemiology of this carbapenemase, you will find that India is ranked amongst USA in some states where we have all the 5 carbapenemase, Turkey, and India. So these are the 3 places where you will find all the carbapenemase against the Enterobacteriaceae. So what next? If the carbapenem resistance is so high, then what are the treatment options available to us for the bugs which are resistant to carbapenem? Now, I've just tried to present you the list of antibiotics which have been introduced over the last 5 to 7 years, and they are FDA approved. So if you look at the list, you'll find this is not a new class of antibiotics. Different classes, different combinations and permutations of the existing class of antibiotics have been tried. And only antibiotic which is available to us among this list is ceftazidime avibactam, which has got activity against OXA48, but it does not have activity against NDM. So if we want to use ceftazidime avibactam, it needs to be combined with aztreonam to give sensitivity against both OXA and New Delhi metallo-beta-lactamase. So what has happened to the choice of antibiotics? So what we are left with, we have shifted our antibiotic choice and gone back to the era of 50s and 60s. So we have gone back to the polymyxins, we have gone back to the tetracyclines, fosfomycin, and sulfonamides. Now, polymyxin is one of the drugs which has become the drug of choice for carbapenem resistant organisms. But even this drug has shown now resistance, and the reports started coming globally beyond 2010. And there is a group which is looking into the genes which is contributing to colistin resistance, and they have identified that MCR, mobilized colistin resistant gene, is one of the most common gene which contributes to polymyxin resistance. And this gene is important because it is plasmid mediated and it is transmissible gene. So this contributes maximum to the resistance to polymyxin. And if we look into the data which is available on polymyxin resistance, as far as India is concerned, we have got very limited Indian data on the epidemiology, on the colistin-resistant isolates, and especially if you look into the ISU settings, we have got very limited studies. All studies which are available to us, they are heterogeneous in nature and they have been done in different patient populations. So with this background, now I would request our third year's DM student, Dr. Mayank, to please go ahead and present the main study.
Thank you, sir. I am Dr. Mayank Sharma, third year DM resident from Department of Critical Care Medicine. And now I am going to present the objectives, material methods, and the results of this study, which was conducted in the Department of Critical Care Medicine. So the primary objectives were to study the clinical profile of patients with polymyxin B and E resistant positive cultures, which were isolated from blood, bowel specimen, and body fluids like intra-abdominal collections and pus, and to study the outcome of patients with cultures of polymyxin B and E resistant isolates in terms of length of ICU stay and outcome at 28 days and at discharge. The secondary objectives were to study the risk factors for the development of polymyxin B and E resistance, like days of mechanical ventilation, need of renal replacement therapy, and days of shock. It was a collaborative study between the Department of Critical Care Medicine and Department of Microbiology. It was a prospective observational study over a period of 2 years from January 2020 to December 2021. The study was conducted after Institute's Ethical Committee approval. We divided patients into the case and control group. The inclusion criteria for case group was adult patients with age more than 18 years with culture showing bacterial isolates which were resistant to colistin. And inclusion criteria for control group was adult patients with age more than 18 years with culture showing bacterial isolates sensitive to colistin. So both the group had patients who are admitted in our ICU. Both group had sick patients. The only difference was for case group, it was bacterial isolates resistant to colistin, and sensitive group has shown cultures, control group has shown cultures sensitive to colistin. The exclusion criteria of patients include age less than 18 years and patients growing bacterial isolates having intrinsic resistance to colistin, like Burkholderia species, Stenotrophomonas maltophylla, Pseudomonas species other than Pseudomonas aeruginosa, and Proteus species. Assuming a minimum effect size of 0.80 for mean difference in the duration of ICU stay between resistant and sensitive patient groups, in our study it was 1.119 at minimum two-sided 95% confidence interval, and taking 90% power of the study, the sample size estimated for cases and control was 25 and 51. Finally, in this study, we have included 28 cases and 55 controls, a total of 83 patients. Continuous variables are presented in median with interquartile range and minimum maximum and compared using Mann-Whitney U test. The categorical variables are presented in number with percentage and compared by chi-square or Fisher-exact test as applicable. The univariate binary logistic regression model was used to assess the factors associated with colistin resistance. The multivariate binary logistic regression model was used to identify the independent predictors of colistin resistance. SPSS version 23 was used for data analysis, and a p-value of less than 0.05 is considered as statistically significant. We collected data from the hospital information system and patient's medical record. The data collected include the baseline characteristic like age, gender, comorbidities like hypertension, diabetes, liver dysfunction, hypothyroidism, rheumatologic disease, cardiac ailments, renal dysfunction, And we also calculated Charlson comorbidity score. The diagnosis at the time of ICU admission, the disease severity score like Apache 2 or acute physiology and chronic health evaluation score, so sequential organ failure assessment or SOFA score at the time of admission and at positive culture, the duration of illness, prior hospitalization, and positive cultures at the time of ICU admission. We also collected data on the prior use of antibiotics or antifungals in the last 90 days. The Apache 2 score or acute physiology and chronic health evaluation score is calculated by summating the age points. The acute physiology score, which included variables like temperature, heart rate, blood pressure, and chronic health points. The total or the maximum score which can be obtained is 71, and it reflects the severity of the disease and predicts the patient outcome on day 1. The sequential organ failure assessment score is calculated by adding 6 parameters from 6 major organ functions. The total score is 24. A higher score denotes a severe disease and predicts mortality. The Charlson Comorbidity Index score is denotes the burden of the comorbidities at the time of admission. It is calculated from these 19 variables. The maximum score is 37, and based on the Charlson Comorbidity Index score, the severity of comorbidities is categorized into 3 grades: mild with a score of 1 to 2, moderate with a score of 3 to 4, and severe with a score of more than 5, and it predicts a 10-year mortality of more than equal to 25%. The European Center for Disease Prevention and Control and the Center for Disease Control, based on the data from the CLSI, UCAST, and FDA breakpoints, have defined the resistant pattern among the bacterial isolates into multi-drug resistance, which is defined as acquired non-susceptibility to at least one agent in 3 or more antimicrobial categories. Extreme drug resistance, or XDR, is defined as non-susceptibility to at least one agent in all but 2 or fewer antimicrobial categories. That is, bacterial isolates remain susceptible to only 1 or 2 categories. And pan-drug resistance is defined as non-susceptibility to all agents in all antimicrobial categories. We also collected data during the ICU stay, which included routine blood investigations like CBC, LFT, AFT, procalcitonin level, and coagulation profile, the days of invasive lines, vasopressor therapy, mechanical ventilation, and days of renal replacement therapy, the antibiotics which were used during the ICU stay, the length of ICU stay and hospital stay, and status at 28 days and at discharge. The bacterial isolates were identified by routine tests like gram staining and biochemical test, and automated systems like MILDITOF or matrix assisted laser desorption, ionization, time of flight, mass spectrometry. The colistin MIC was detected by epsilometer strip test or E-test, Vitek2, and broth microdilution test. And detection of various genes like MCR and other variants was done by PCR technique. According to the recent CLSI or Clinical and Laboratory Standard Institute guideline in 2020, a value of MIC more than equal to 4 was used to diagnose colistin-resistant isolates in culture, and these patients were included as cases. Now coming to the result. This table shows the distribution of the demographic and clinical variables between cases and control. As we can see, all the baseline characteristics like age, sex, and comorbidities are similarly distributed in the control and case group. The median age in the control group was 46 with 65.5% males, and in the case group it was 47 with 60.7% males. The median Charlson comorbidity score was 1 in controls and 2 in the case group or colistin resistant group. The disease severity scores like SOFA score and Apache 2 score was significantly higher at the time of admission in the patients included in the control group as compared to case group, which denotes a higher severity of the disease at the time of admission in the control group. Other variables like SOFA score at positive culture, procalcitonin level at admission and at positive culture were similarly distributed between the two groups. This is a bar diagram showing the distribution of the various comorbidities in the cases and control. The red bar denotes the cases and the blue bar denotes the controls. The total number of patients who were admitted during our study period were 532. 28 patients grew colistin-resistant bacterial isolates in their cultures, which is 5.2%. The most common diagnosis on admission was intra-abdominal sepsis, either due to pancreatitis or GI sepsis, followed by pneumonia. Comorbidities like diabetes, asthma, COPD, and malignancy was more common in patients which were included in cases as compared to controls. This table shows the comparison of risk factors for the development of colistin resistance. Based on the review of previous studies done to find the risk factors associated with colistin resistance, we identified and collected variables of before and during the ICU stay. Among the variables of the data collected before the ICU stay, as we can see, the days of exposure to colistin before ICU admission was significantly higher in the cases as compared to controls. Other variables like days of illness before ICU admission, days of hospitalization before ICU admission, days of exposure to carbapenem and antifungal were similarly distributed in the two groups. In the data that was collected during ICU stay, the total duration of ICU stay, the total days of invasive lines, days of mechanical ventilation, days of vasopressor therapy during ICU stay, days of colistin use, carbapenem use, antifungal use, and monobactam use, and surgical intervention, which included laparotomy, mini laparotomies, ward procedure, and PCD insertions, was significantly higher in the cases or patients which had resistant colistin resistant culture as compared to controls. Variables like days of renal replacement therapy during the ICU stay was similarly distributed in the two groups. When we did the univariate analysis of these factors, we found that there were 14 variables which were significantly associated with colistin resistance. Among the factors associated with colistin resistance before admission to our ICU were prior exposure to colistin in days and prior exposure to carbapenems. The factors which were associated with colistin resistance during the ICU stay of the patients included the total duration of stay, the days of vasopressor therapy, the days of mechanical ventilation, invasive lines, exposure to monobactam in ICU, exposure to colistin, surgical intervention, the colistin, total duration of colistin, carbapenem, monobactam, and antifungal use in the ICU, and the change in the procalcitonin value on positive culture. This is the forest plot showing the univariate analysis of factors which were associated with colistin resistance. As we can see, three variables stand out, which with highest odds ratio for exposure to monobactam in ICU, followed by exposure to colistin in ICU, and surgical intervention. We also did the multivariate analysis to identify the independent predictors of colistin resistant, which included prior exposure to colistin, exposure to monobactam in ICU, and ICU stay in days. Since we have seen earlier that the severity of the illness between the cases and the control group was different, and it was significantly higher in patients which were included as controls, we tried to adjust for the severity at the time of admission using propensity score matching based on the SOFA at the time of admission, in which 28 cases and controls were exact match. The multivariate analysis of all the factors showed the same three factors which were independently associated with colistin-resistant, that is prior exposure to colistin, exposure to monobacterium in ICU, and ICU stay in days. This is the forest plot showing the multivariate analysis of factors which were associated with colistin resistance. As we can see, the highest adjusted odds ratio is for prior exposure to colistin, followed by exposure to monobacterium in ICU. When outcome of these patients were compared, we found that in the initial 28 days, there was a higher proportion of the patients in the control group dying, with 74.5% mortality in the control group as compared to 39.3% in the case group, and it was significantly higher in the control group. One reason could be the increased severity of the disease at the time of admission in the control group. However, in the final outcome analysis, we find that there is no statistically significant difference in the mortality between the cases and the control group, though the mortality was still higher in the control group. We tried to adjust for the severity of the disease at the time of positive culture using propensity score matching, in which 23 cases and controls were exact matched. The outcome analysis of these patients showed that although the proportion of the death in the cases was higher as compared to controls, but still it was statistically non-significant, with odds ratio of death in cases was 1.24 and a p-value was 0.744. This is a graph depicting the same, showing the percentage mortality at discharge in the unmatched patient population. The blue bar denotes the controls and the red bar denotes the cases. Though after propensity score matching, the proportion of the death in the cases have increased, but it is still non-significant. It could be because of the small sample size in the present study. This pie chart shows the various specimen samples from where gram-negative bacteria were isolated. The most common site was blood in both cases and control, which is represented by the blue color, followed by pus in red color and ball in green color. The most common species which was isolated from specimen sample was Klebsiella pneumonia. It was identified in 96.4% of patients in the case group or patients who had resistant colistin-resistant isolates, as compared to 50.9% in the control group, and it was significantly higher in the case group. The other species which were identified were Pseudomonas aeruginosa, Acinetobacter baumannii, E. coli, and Enterobacter. Among these, Acinetobacter baumannii and E. coli were significantly higher in the control group. This is a bar chart showing the various species which were identified in different specimens like blood, pus, and ball in both the control and the case group. We also tried to study the resistant pattern in our cases or the colistin resistant population. The distribution showed that pan drug resistant was identified in 10 cases, 7 of which were isolated from blood, 3 from pus, and all grew Klebsiella pneumonia. 8 of these patients died and 2 survived. Extreme drug resistance or HDR was identified in 17 patients. 12 were isolated from blood, 3 from pus, and 2 from ball. All were Klebsiella pneumoniae. 12 of these patients died and 5 survived. Multidrug resistant was identified in 1 patient, which was grown from blood and which grew Pseudomonas aeruginosa. That patient ultimately survived and was discharged. We tried to study the antibiotic sensitivity pattern amongst our cases. amongst our cases which are colistin-resistant, we find that the highest sensitivity was for tetracycline, which was 60.7%, followed by ceftazidime avibactam, 32.1%, and ceftriaxone in 21.4%. Other antibiotics to which these cases or colistin-resistant patients were sensitive were aminoglycosides, fluoroquinolones, and beta-lactams. None of the cases was sensitive to carbapenems. We study and compared between the bloodstream infection in our control and case group. 41 patients in the control group and 20 patients in the case group grew gram-negative isolates from their bloodstream. The most common species and that was identified was Klebsiella pneumoniae, which was found in 95% of cases and 53.7% of control. And as compared to the previous, as similar to the previous result, as we can see that it was significantly higher in the case group and was associated with resistance. Other species which were identified were Pseudomonas aeruginosa, Acinetobacter baumannii, E. coli, and Enterobacter. Among the case group, that is the 20 patients, PDR was found in 35%, extreme drug resistance was found in 60%, and MDR was found in 5%. We also did the genotypic analysis of cases or the 28 patients with the help of Department of Microbiology. 3 genes were identified via polymerase chain reaction, which was mobilized colistin resistance gene or MCR1 gene, NDM1 gene, and OXA48. The MCR1 gene was identified in 5 cases, 2 of which had pan drug resistance and 3 had extreme drug resistance. All of these patients died and all of them grew Klebsiella pneumoniae and they had a variable sensitivity pattern. The NDM1 gene was identified in 8 cases. 5 of these had pan drug resistant, 3 had extreme drug resistant. 75% of these patients died. All grew Klebsiella pneumoniae. All were resistant to carbapenem. 3 were sensitive to tetracyclines and rest were PDR. OXA48 was identified in 9 cases, 1 of which was PDR, 8 were XDR. 77.8% of these patients died. All grew Klebsiella pneumoniae and they were sensitive to ceftazidime avibactam. So in a patient population which is resistant to colistin, and if we find NDM1 gene apart from aztreonam, we can try tetracyclines. And in patients in which OXA48 has been identified, they're usually sensitive to ceftazidime avibactam, and we can try this as an empiric therapy. In summary, the percentage of colistin resistance in our study population was 5.2%. The exposure to antibiotics, especially colistin monobactam, prior and during the stay was significantly associated with resistance to colistin. The surgical intervention after admission to ICU was significantly associated with resistance to colistin. The commonest organism which was identified in cultures was Klebsiella pneumoniae, and the most common site of isolation was blood in both group of patients. The genotypic analysis can be used to decide therapy in colistin-resistant cases. Now I would like to invite Dr. Manish Gupta for review of literature.
Thanks, Dr. Mayank. I'm Dr. Manish from Department of Critical Care Medicine. Now, before moving to the review of literature, I want to highlight the strengths and limitations of our study. Now, it is the first prospective case control Indian ICU study to study the epidemiology of colistin resistance, but being a single center observational study is one of the limitations. Most of the baseline characteristics were evenly distributed between the cases and the controls, but the cases and control were not matched for the severity of the disease at the time of the admission. Now, antibiotic treatment options based on the gene analysis were highlighted, and the gene analysis of the colistin-resistant isolates was done to study the mechanism of the colistin resistance. But the colistin as a monotherapy or as a combination therapy, it was not taken as a risk factor into account. We have only limited cases, that is 28 cases for gene analysis, and we could only identify the gene analysis in the Klebsiella pneumoniae species. We were not able to identify the gene analysis among Pseudomonas species, and the role of cross contamination of colistin resistance from other patients was not studied. Now, the literature on the colistin resistance is very heterogeneous. Some have studied only the risk factor, some have studied the mortality, and very few studies have touched the gene analysis. Now, there is a paucity of the Indian literature on the colistin resistance in the ICU settings. Now, we will study some of the international literature. Now, this is a multicentric retrospective case control study published in the Clinical Microbiology and Infectious Disease Journal in 2015. It is about the risk factors for bloodstream infections due to colistin-resistant KPC producing Klebsiella pneumoniae. It was a result from a multi-center case control study. It was done in 6 teaching hospitals in Italy. The study period was nearly 4 years, and they identified nearly 729 bloodstream infections due to Klebsiella pneumoniae, and out of that 19.5% were colistin-resistant strains. And when they tried to look upon the risk factors associated with the colistin resistance, previous colistin administration, the previous pollination with KPC, that is Klebsiella pneumoniae Carbapenems, and more than equal to 3 hospitalization, and the Charlson comorbidity score more than equal to 3, and neutropenia was significantly associated risk factor with the colistin resistance. In our study, the previous colistin administration, the previous monobacterium exposure, and the length of the ICU stay were a significant risk factor. Now, this is a retrospective single-center study in the USA, published in 2018 in the Journal of Clinical Microbiology. It was among the risk factors for colistin resistance among gram-negative rods and Klebsiella pneumoniae isolates. They identified nearly 12,000 patients, and out of that 28,500 GNR isolates were identified, and the colistin resistance prevalence of the colistin resistance was only 0.44%, that is less than 1%. And when they tried to look upon the risk factors, the neurological disease, facility prior to admission, the use of carbapenem in the prior 90 days, and the mechanical ventilation, either invasive or non-invasive, and the prior carbapenem resistance was significantly associated risk factor with the colistin resistance. Now, this is a recent study published in the Infectious Disease Journal and endorsed by ITSA. It is a retrospective case control study, and it tried upon the risk factors and the mechanism of colistin resistance among Enterobacteriaceae. It was done at Michigan Medicine Hospital, USA, and the study period was nearly 14 months. And then they studied nearly 16,000 isolates, and out of that, only 166 were colistin resistant, that is 0.99%. And we can see that even in the Western world, it is less than prevalence of colistin resistance is less than 1%, but still they are coming with so many guidelines, and they have cited colistin resistance as a threat to their economy by 2050. And urine was the most common source of the isolate, colistin-resistant isolate. In our study, it was the blood, and we have not included urine as our because considering a colonizer in our study. And most common organism among the Enterobacteriaceae, and they found as Enterobacter. In our study, it was Klebsiella pneumoniae. When they tried to look upon the risk factors associated with the colistin resistance, the age more than 55 years, and the antibiotic exposure in the previous 90 days was associated with the colistin resistance. And they also tried to look upon the gene analysis, and what they found that MCR1 gene, PMR A and B genes, and MGRB genes were predominantly associated with the colistin resistance. Now, coming to the Indian literature, this is a prospective single-center study from KIMS, Karad, Maharashtra. It is about the emergence of colistin-resistant gram-negative bacilli from a rural hospital from Western India. It was published in 2016, and study period was nearly 1 year. And they isolated nearly 3,600 GNB isolates, and out of that, nearly 10% were colistin resistance. Now you can see the even 6 years back, such is the high prevalence of the colistin resistant in the Western India, that is region nearly Mumbai. And Pseudomonas species were the most common organism, and the PERS showed the maximum colistin-resistant isolates. Now, again, this is a retrospective single-center study from Apollo Hospital, Chennai. It was published in Indian Journal of Critical Care Medicine in 2017, and they have taken cutoff of colistin resistance as MIC more than equal to 2. In our study, as per the latest CLSA guidelines, we have taken colistin-resistant cases as MIC greater than equal to 4. This may be the reason for a little bit higher number of cases. And out of they identified nearly 24 colistin-resistant isolates in an 18-month period. And out of that, 16 were true infection and 8 were colonization. And the urine was the most common source of isolate because they also identified colonized isolates. And the most common, as in our study, it was the Klebsiella pneumoniae species. And the maximum death was among the bacteremic patients. But there was no death among 8 colonization isolates. So we can infer that there is no need to treat colonization because most of the colistin-resistant isolates reflect colonization. And there is no death among the 8 colonization isolates. Now, this is a retrospective observational study to study the pattern of the colistin resistance in a Klebsiella isolates in a single center at the Apollo Hospital, Ludhiana. And the study period was nearly 3 years. And they studied nearly 2,500 bacterial isolates. And out of that, 21% was Klebsiella species, and only 1.28% were colistin resistant. And the blood was the most common source of the colistin resistant isolates. And the good part was that all the cases were sensitive to fosfomycin. And this drug we currently is in our drug armamentarium. Now, this is a recent last year article. It is a prospective observation case control study from Gangaram Hospital, Delhi. It was published in American Journal of Clinical Microbiology. And they studied the risk factors and outcome of colistin-resistant infection, only Klebsiella pneumoniae infections as the most common infection. And what they found that out of 3,100, nearly 3,100 patients, 155 Klebsiella pneumoniae infections were there, and 37.4% were colistin-resistant Klebsiella pneumoniae infection. You can see the such high prevalence of colistin resistance in a Delhi NCR region. In the Western world, it is only less than 1%. Still, they are so much worried. And what they found that ventilator-associated pneumonia was the most common nosocomial infection. When they tried to study the risk factor, that it was not significantly associated with the colistin resistance. But what they found that the presence of the central line and the resistance to colistin were independent predictors of mortality. Now, this is a case which we want to highlight. Out of our 28 colistin-resistant cases, 10 were pan-drug resistance, and out of that, 2 survived. This is one of the survivor, and he recently, 15 days back, he visited our ICU. He was a 31-year-old male from Bihar and admitted with severe acute pancreatitis with septic shock. He had a prolonged course in the ICU, nearly 2 months, you can see, with multiple episodes of systemic shock, intra-abdominal bleed, and later on he was tracheostomized and undergone video-assisted retroperitoneal debridement. He has multiple abdominal PCDs, and blood grew Klebsiella pneumoniae multiple times, and which was PDR, and it was OXA48 gene. And we used combination therapy with a high dose tirecycline. So we can, if we are faced with PDR bug in ward or any, we should not leave that patient. So pan-drug resistance is not a death warrant, because whatever this PDR, MDR, XDR is based on the MIC which is done in the laboratory in vitro. So if we are using combination therapy and high dose therapy, we can still achieve the PK/PD. So what's the take-home message? That emergence of colistin resistance is increasing at alarming pace in the Indian ICUs, and we should follow the principles of antimicrobial stewardship. We should avoid the empirical use of colistin. We should avoid treating the surveillance cultures. We should avoid use of colistin other than for the treatment of culture-proven organisms. We should avoid treating colonizers, as most of the colistin-resistant isolates reflect colonization. We should emphasize on infection control policies like hand hygiene to prevent the cross-contamination of colonization from other patients, and microbiology can help to fill the serious data gaps. We acknowledge the support from the Department of Microbiology and Biostatistics. Now, since we have only limited options left for the treatment of colistin-resistant isolate, so best strategy is prevention, and in prevention, hand hygiene is the topmost priority. Thanks.
Thank you. Good morning. I just wanted to, from microbiological point of view, I just wanted to say 3 to 4 points. As in this, you have seen in this presentation, the colistin resistance is very much alarming, especially in Indian ICUs. So, because in comparison to Western world, Indian isolates, there are more of ESBLs and NDM and high prevalence of other antibiotic resistance genes and combination of genes. So the colistin is often the last choice of antibiotics, especially against the Carbapenem resistance gram-negative bacterial isolates. So resistance to colistin is a very worrisome feature in our isolate, especially in our ICU settings. So optimal use of this colistin is very much important, as the new drug development, the pace of new drug development or new antibiotic development is very less as compared to the pace of bacterial drug resistance development. So bacterial drug resistance to colistin, it can be intrinsic drug resistance, as I've been told, or acquired drug resistance. Some bacteria, especially colonizers like Carbapenem, Proteus, Stenotropomonas, Burkholderia, they are intrinsically resistant to colistin because they don't have any receptor or they have very high plus bounds to colistin. So in these bacterial isolates, the colistin use should be avoided. And for acquired drug resistance, the bacteria, it can be either by mutation or either by plasmid mediated. So mutation it can be due to the disruption of MGRB gene, because MGRB negatively regulates the altered receptor of the colistin. So when there is mutation of MGRB gene, there is upregulation of altered protein binding side of the colistin. So the colistin cannot bind to the bacterial protein, so it becomes resistance. But we are not very much worried about the about the mutation, because in mutation only the particular bacterial clone is resistant to colistin, but it can transfer its resistance to other bacteria. However, the MCR1 gene, the plasmid mediated resistance, that was first discovered in China, and it is very much worrisome because MCR1 gene, it produces altered colistin binding proteins, and it can transmit its resistance to all the bacterial clones. And a clone of bacteria, if multiple lakhs and hundreds of bacteria, lakhs and crores of bacteria, they become resistant to this colistin. So it is very much worrisome features. So to prevent this, proper hand hygiene, PP, and other infection control measures and optimal antibiotic use is very much important. So colistin susceptibility can be detected by various methods. We use E-strip method or broad microdilution or automated methods like HiTech. So the recommended method is broad microdilution, but because it is very much cumbersome and we cannot day-to-day basis, we cannot do 100 and 200 isolates. So various studies have found that E-strip and HiTech also very good in detecting the colistin resistance. So we can use in this to detect the colistin. And also it can be seen, for the interpretation, it can be said that the colistin and polymyxin B, they can be interpretationally interchangeable. That is, colistin, if the bug is sensitive to colistin, then it is sensitive to polymyxin. It is resistant to colistin, then it is also resistant to polymyxin B, and vice versa also. So both interpretation can be changed interchangeably. But there is clinical polymyxin B and the colistin, they differ in the clinical uses and the pharmacokinetics. As colistin is excreted mostly in the urine, so it is better choice in urinary tract infection as compared to polymyxin B. But for bloodstream infection, as you know, the colistin is a prodrug. It is administered colistin sulfonate, so it is converts to colistin in the bloodstream infection. After that, it can work. So that's why you have to give a loading dose for colistin. So for bloodstream infection and sepsis cases, polymyxin B is a better choice than colistin because it has very good plasma level. And for inhalational antibiotic for ventilator-associated pneumonia cases, polymyxin B is not recommended for inhalational therapy. Colistin is recommended in these cases. So for resistance, we have fortunately we have less than 2 or 3% resistance cases, especially in E. coli and other bacteria. But for Klebsiella, it is sometimes 5 to 10% resistance we have seen. So in particular in Klebsiella cases, the colistin is very much the resistance is worrisome. Thank you.
All right. Well, thank you.